Okay, so firstly, we would like to take this opportunity to commemorate all women who had and are currently resisting patriarchy and fighting for their rights. Women in detention are stigmatized and face greater barriers when it comes to access to health and harm reduction. So this will also be an opportunity to discuss pathways for their protection. Currently, there are over 11.5 people deprived of liberty who have been disproportionately impacted by the COVID-19 pandemic. The virus spread through prisons at higher rates than in the broader populations because of their poor and overcrowded conditions, alongside inadequate prison health services due to decades of neglect and underinvestment. At the same time, people in detention have been found to be at significantly increased risk from COVID-19. Members of vulnerable and marginalized groups, such as people who use drugs, are overrepresented in prison settings. And many of the factors that make these groups more likely to be incarcerated, such as poverty, discrimination, and drug use, also mean that they tend to carry disproportionately high burden of disease and ill health. And this, of course, increases their risk of becoming seriously ill if they contracted COVID-19. So there absolutely was and continues to be a need to prevent the spread of COVID-19 in prison and prioritize people in detention in global, regional, and national response to the pandemic and beyond. But as we'll hear from the speakers today, efforts to control and prevent COVID-19 in prison settings have not only been challenging, but also very problematic. In many cases, the measures used have actually made people in detention more vulnerable to health and human rights harms, and we need to do better. The objective of this webinar are simple. We want to provide an opportunity for people to come together to share and learn about experiences, challenges, failings, best practices, and lessons learned on addressing COVID-19 in prison settings in order to better protect the health and rights of people in detention during the current pandemic and in future health or other emergencies. Before we start with the first speaker, I would like to also share that HRI just published a briefing on the linking the pandemic treaty processes and the protection for people in detention. My colleague Marcela will share the link as well as the briefing on the chat. This is, we just launched it today, so hopefully it would be a good reading. It would be a useful reading for you and for your advocacy work. But if I may say at least a few things from the briefing. In December 2021, the World Health Assembly established an intergovernmental negotiating body, or it's called INB, to draft and negotiate an international instrument to strengthen pandemic prevention, preparedness, and response among state members. And this piece of international instrument is known as the Pandemic Treaty. Nevertheless, the zero draft of the so-called Pandemic Treaty, does not acknowledge people deprived of liberty as vulnerable subjects, nor places of detention as settings that require specific attention. And currently, this pandemic treaty, the zero draft, is being negotiated at the WHO. So on this briefing, we outline key reasons for addressing the needs of people deprived of liberty in the pandemic treaty and provides recommendation for amendments in that sense. Because as I mentioned earlier, it is critical to make sure that pandemic prevention and preparedness and response address the special needs of people deprived of liberty. So I'll start by explaining the agenda for today. We will first hear from Jen Sander, who will introduce us the latest HRI's report on prison and COVID-19, which is being launched today as well. And you can also find it on our website. And then we will hear from experts and advocates on the ground about how COVID-19 impacted and continue to impact people in prisons. We have here advocates from Kenya, Moldova, and Mexico. So I hope while listening to their presentations, you can start preparing your questions for them. And as always, I forgot to introduce myself. I'm Ajeng Larasati. I'm the Human Rights Lead at Harm Reduction International, and I will be moderating the process today. So now, without further ado, I'll present you our first panelist, Jen Sander. Jen Sander is a human rights consultant at Harm Reduction International. Jen has been working with HRI since 2014 and monitoring trends on violations of fundamental rights committed in the name of drug control, with a focus on prisons and the death penalty for drug offenses. Jen has worked with human rights NGOs in Canada, Europe, and the Middle East, and has also been a consultant for the World Health Organization and the Independent Expert Review Group on the right to health issues. Jen holds an LLM in Economic, Social, and Cultural Rights from the Irish Centre for Human Rights. Jen, the place is yours.
Thank you so much. Thank you for that introduction, Ajeng. And a big hello and thank you to everybody joining us today. Marcella, can I have my presentation shared, please? Unfortunately, it wasn't working for me to share my slides, so my wonderful colleague, Marcella, will be sharing when she can. Thank you so much. So as the title of my presentation suggests, I'm going to be looking at how COVID-19 responses in prisons have impacted the provision of health and harm reduction services, as well as human rights. Next slide, please. Specifically, I'm going to be sharing some of the findings from HRI's most recent report, Prisons After COVID-19, Beyond Emergency Measures. The report delves into these issues and focuses on the 15 countries that you can see I've listed in the slide here. For more information on how we selected these countries or any other methodological questions you might have about this, please do go check out the report. Next slide, please. So all the 15 countries that we looked at adopted various measures to curb the spread of COVID in prisons, including some more extreme ones, and those are the measures that I'm going to be focusing on today. Full lockdowns were implemented in prisons in all of the countries at the beginning of the pandemic and at various other stages of the pandemic. These saw people in most countries confined to their cells for sometimes 23 or 24 hours a day, and a full suspension of regular activities. In many countries, these lockdowns were prolonged, sometimes lasting for months at a time. They were indefinite and they were reoccurring. Preventive quarantine for new arrivals to prisons, for returnees or transfers between prisons was implemented in many countries as well, including in Benin, Burkina Faso, Canada, France, Italy, Switzerland. At its most extreme, preventive quarantine isolated people in their individual cells for as much as 23 hours a day and lasting up to 24 days. In most cases, preventive quarantine was mandatory, sometimes even if people were vaccinated against COVID, rather than based on an individual assessment of risk of infection. All countries also suspended or severely restricted prison visits, which prevented not only family and friends from coming into prisons, but also external service providers, including harm reduction and other service providers. Even with these measures in place, prisons in most countries that we looked at still experienced COVID outbreaks. Next slide, please. These measures, despite of course being well-intentioned and maybe even necessary to a point, had the effect of reducing the already limited availability and accessibility of key health and harm reduction services in prisons in most of the 15 countries that we looked at. Lockdowns and preventive quarantine severely limited or even fully suspended people's access to essential services for extended periods of time. Mandatory preventive quarantine for returning detainees became a serious obstacle to accessing outpatient care, with some people even refusing it despite the health risks associated, just in order to avoid having to spend weeks in preventive quarantine on their return. The suspension of visits had a really big impact. It made it difficult or even often impossible for external service providers to enter prisons for extended and recurring periods. Now, as I'm sure most of you know, external service providers are often responsible for providing a bulk of essential health and harm reduction services and resources in prisons in many countries. In the 15 countries that we looked at, the suspension of visits impacted the provision of essential harm reduction services, mental health care, testing and treatment for HIV, viral hepatitis, tuberculosis, and transfers to hospitals for specialist appointments and care. In some countries, the effects are still being felt today. Now, a shortage of essential medicines and medical staff in prisons was also reported in 9 countries. Next slide, please. In some countries, these emergency measures continue to be implemented in prisons years into the pandemic. And in some cases, they're still in place today, raising questions as to their exceptional or temporary nature. Lockdowns continued to be imposed in prisons long after they were lifted in the broader community in most countries. In the UK, for example, a large proportion of people in detention were still being locked up for 23 hours a day in February 2022, 2 years after the outbreak. Preventive quarantine continues to be applied for prolonged periods in Canada and France, and likely more countries too. And while prison visits have resumed in most countries, they're not like they were before. They're often less frequent and much more restricted now. Visits remain entirely suspended in some Canadian prisons, and visits in at least 4 prisons in Mexico have been permanently reduced. So the prolonged nature of these measures have resulted in the severe isolation of people in detention and have caused very serious harm to their already fragile mental health and well-being. Suicide rates have skyrocketed among prisoners in most countries, with accounts of suicidal thoughts, self-harm, extensive despair, and widespread trauma reported. Next slide, please. Of course, these measures have also had very serious human rights impacts. Before I go into these, I think it's worth quickly emphasizing, in case there was any doubt, that people in detention retain their human rights, including the right to health and the right to be free from torture and ill treatment. These 2 fundamental rights are very interrelated, especially in prison settings. They both impose positive obligations on states to ensure adequate provision of healthcare without discrimination, access to preventive health services, including harm reduction services, access to essential medicines, including opioid agonist treatment, OAT, and access to the underlying determinants of health, including adequate living conditions and access to fresh air. Next slide, please. Now, human rights law does allow for the limitation of some rights in a time of emergency, but these must comply with specific criteria, including proportionality and necessity. While the extremely restrictive measures that were applied may have been justifiable and proportionate for a time, the longer they remained in place, especially when they remained in place long after they were lifted outside of prisons, the more this became questionable. Prolonged lockdowns, preventive quarantine, and visit limitations have caused and continue to cause an extraordinary level of harm, including on the mental health of people in detention, and by limiting the provision of essential health and harm reduction goods and services that they have access to. As less restrictive means of controlling COVID became more available, such as prison decongestion schemes, vaccines, rapid tests, these should have replaced the more restrictive ones. The fact that some of these measures the extreme measures that I was talking about, lockdowns, quarantine, limitations of visits, the fact that these measures are still being used suggests that they've become normalized and routine practice, as opposed to temporary in nature. So for these reasons, the use of restrictive measures in prisons in some countries likely failed, at least at a certain point, to meet the criteria to justify their use. This would have made them disproportionate, arbitrary, and abusive, giving rise to concerns that they could in some cases amount to violations of the right to health and the prohibition of torture and ill treatment. Next slide, please. Some people in detention also appear to have experienced violations of some of their absolute rights. These are rights which can never be limited, even in times of an emergency. In the context of our report, these rights include the right to access health facilities, goods, and services on a non-discriminatory basis, the right to essential medicines, and the prohibition of torture and ill treatment. Some of the measures adopted to prevent and control COVID in the 15 countries that we looked at likely had the effect, either directly or indirectly, of violating these absolute rights by obstructing access to essential medicines and by obstructing access to essential health services for people in detention for extended periods of time. Next slide, please. The use of extended lockdowns and preventive quarantine in many countries also had the effect of subjecting people in prisons to prolonged and indefinite isolation regimes, which may have amounted to solitary confinement or even prolonged solitary confinement. Solitary confinement is when prisoners are confined for 22 hours or more a day without meaningful contact, and it should only be used in exceptional cases as a last resort and for as short a time as possible. It should also only be imposed if no alternative protective measures can be taken by authorities to prevent and respond to the spread of infection in prisons. It also appears that lockdowns, preventive quarantine were in some cases arbitrary, excessive, and effectively constituted solitary confinement or even prolonged solitary confinement as defined by the Nelson Mandela rules. These have had an extremely detrimental impact on the health and well-being of people in detention and could, for these reasons, in some cases amount to a breach of the prohibition of torture and ill treatment. Next slide, please. So to wrap this up, I'd just like to share a few concluding remarks. First, the severe measures imposed in prisons in the 15 countries that we looked at were often disproportionate and have had the impact of making people deprived of their liberty more vulnerable to health and human rights harms and abuses. Second, while COVID represented an extraordinary challenge for governments and prison authorities, they had and continue to have an obligation to apply a human rights framework and to prioritize more effective and less restrictive approaches to manage the crisis and to minimize the negative impacts on prisoners' health and human rights. It seems undeniable at this point that lives could have been better protected by other less restrictive means. And finally, as we come up to 3 years since the outbreak, we must now reflect closely on the failings and the lessons learned, and ultimately on how the rights and the health and the well-being of people deprived of their liberty could have been and can be better protected going forward. In this regard, alongside loudly advocating for decarceration and decriminalization, we need to work to ensure that initiatives to set the standards and policies for pandemic prevention, preparedness, and responses at the international level pay specific attention to the particular needs and experiences of people deprived of their liberty. Next slide, please. So I'll just take the opportunity to reiterate what Ajeng said already. HRI has just released a new briefing that outlines some of the key reasons for addressing the needs of people in detention in the pandemic treaty, and it provides recommendations for amendments in that sense. So I think we have sent you all the briefing, so I would invite you all to take a look at that when you can. Next slide, please. Thank you very much. That's everything from me. Please do go take a look at our new report, and I'm looking forward to hearing from the other presenters and having a discussion at the end. Thank you very much.
Thank you so much, Jen, for your presentation. It looks like now the people outside in general population are already moved on from COVID-19, but the situation in prison is not looking great based on the report that you just shared. Thanks so much for that. I would like to invite the next speaker, who is Hussein Taib. Hussein Abdullah Taib is a social worker and currently head of advocacy with MEWA Health and Harm Reduction Services. He has worked with people who use drugs for more than 2 decades. And through this period, he has witnessed steady growth in access to health and human rights in Kenya and beyond. Hussein will present key lessons from the establishment of the first MAT clinic in the Shimola Tewa prison in Mombasa. I hope I pronounced that right, Hussein. The floor is yours.
Thank you very much. Asante sana. Can we have the first slide, please? Can I have the first slide there?
Yes, let me check. Marcela, would you be able to help with the slide for Hussein? Thank you so much. Sorry, Marcela, that's the wrong screen. Please bear with us for a few seconds. Perfect.
Hi, okay, thank you very much, Asante sana. As said by Jen, she actually sort of summarized the whole scenario, what COVID-19 did to every one of us. Actually, what we'll be talking is about, as per the screen above, improving policy and practice in human rights, health and human rights for people who use drugs in correctional facilities and beyond. Next slide, please. Yes, at a glance, MEWA is an NGO, and we have been working with people who use drugs for the last 20 years. Initially, at the late 20s, late 90s, we started with awareness program and prevention. It was about abstinence. By 2010, that's when we embraced harm reduction intervention. And it was in 2014 that we got our first MAT clinic in the country. And in 2015, that is when we had the MAT clinic in Mombasa. And throughout this period, we were working with people who use drugs, doing everything right. But when it came to them getting into conflict with the law, that was the end of us and our engagement. So it was taking a big toll towards the rights and privilege of people who use drugs. It was until in 2015, that is after we got some support from Open Society Foundation, that is when we started the paralegal department. And it began, as you can see on the screen, we started with training of prison wardens. From this training, we got to understand, to know a lot of issues that were in the correction facilities. And we use these as the bridging stone, the stepping stone for us to be able to reach the list of law enforcers and the judicial services. So in 2015, we also signed a MOU with the judiciary services, where we could now start working at the law courts. So from that time onwards, we were steady working and accessing services for people who use drugs. In 2016, we started prison visits, and we went on to do this until in 2015. In 2014, when we started the methadone clinic, methadone program, that is when we rolled our head to see how best we can actually help continue the program, because majority of our clients ended up in prisons. And once they got into the prison, and that was the end of it. There was nothing we could do, and they stood to disrupt the program. So in after the COVID in 2019, we worked very hard to make sure we raised our voice, did advocacy to make sure people realize, the government realized there is a need for people in detention facilities to access holistic healthcare and rights services. So this is what it is. Let's go to the next slide, please. Yes, our guiding principles is, of course, the international conventions. We actually relied on these to try to push the system, the policymakers and the duty bearers on the importance of engagement of people who use drugs in different capacities and different services provided in the country. So the Kenyan Constitution, Article 43, is giving us the right for the highest attainable standard for all the citizens. Article 48, access to justice, give us the opportunity for people who use drugs and the rest of the community to access justice. So we actually banked on these, plus the the law, Narcotic Drug and Psychotropic Substance Control Act. This was a very important act that was actually negatively used to suppress people who use drugs. You're only using the parts of punishment and forgetting part 4, there was an element of rehabilitation. This was at the end of this law. So we actually used this to advocate for the rights of the service, for the rights of the people. So part 4 was talking about rehabilitation, where it gave the government the mandate to establish rehabilitation centers all over the countries. There was a need for advisory council. There was a need for establishment of and management of a fund, but these never existed. This act was actually in, this law was enacted in 1994. And from 1994 to date, nothing has been done in terms of rehabilitation centers. It was only recent that these people, I mean, the government has come up with it. Another thing was committal of person to treatment center. This was another section that was in the act, in the law, but it was silent. Nobody was actually using it. So in our campaign, in our advocacy, we had to base our argument on all these legal matters for us to be able to be listened to and to reach where we are. Next slide, please. Yes, the need for MAT services. From the establishment of the MAT services, a lot of drug users were actually being incarcerated for petty drug-related crimes, and there was a fear that the methadone program, the OST program, was going to fail. So what we did, we worked very close with the legal justice system, and we were using the constitutional article of the Kenya Constitution. And from the data that we generated, from the reports that we monthly generated, we showcase of the importance of engagement on establishment of a MAT clinic at the maximum facility here in Mombasa. Because in Kenya, we live at the coastal area where there is a lot of effect of drug abuse in this country. All the concentration of drug use is found where we are. So a lot of people were actually being found using drugs, and they ended up in prison. So the MAT clinic that was established by the government, United Nations, UNODC, was about to collapse. So what we did was we gathered information and we proved that there was need for establishment of a methadone clinic at the Chimolatewa prison. So the increase of MAT clients at the prison through court orders. So what was happening is, for drug users, initially, they had no rights whatsoever, absolutely. Through our engagement with the law court, all the drug users, as long as somebody accepted, was a drug user and was in need of services, was given special attention, was referred direct for methadone clinic, the one that is actually outside in town. So after some time, it was noted there were a lot of drug users in the prison, and the prison authority had to take them on regular basis for the methadone clinic elsewhere, and that was quite demanding. And they didn't have the resources for doing this. So from the numbers, we actually worked very closely with UNODC to make sure our cries were heard. And after some time, the methadone clinic was established at the Chimolatewa prison. Next slide, please. So the historical breakthrough. The methadone clinic was established, but because of resources, the methadone clinic was just a structure and nothing was actually happening on the ground. So when the COVID came, it came with a blessing for us here in Kenya, because we took this opportunity to push for the opening of the methadone clinic that was already established, that was already built at the correction facility. but because of staffing and other structural engagement, nothing could have happened. So we continue to advocate, and the data and reports that we managed to get was enough to push. So active collaboration between MEWA and the criminal justice system. We're working very close with the criminal justice system, and the drug users under inside the prison were suffering, and we had to shout it out to the justice system. These guys were actually serving, and court orders were actually issued from the courts to the prison authority to make sure the drug users inside the prison had to access methadone during the COVID lockdown. So this open was a blessing for us. So when it came to issue of staffing, they didn't. The prison authority didn't have enough personnel. So it was MEWA, the NGO, that gave initial support. Up to today, almost 80% of the staff are engaged at the Shimulatewa MAT clinics are staff that are actually supported by MEWA. So this was from the availability of staff and experience and expertise from our side, the CSOs. So it was easy for the clinic to be open, and the inmates were actually getting access to the methadone. So next slide, please. Yes, prior to the COVID pandemic, these are the services that we were actually providing at the prison facilities. We were providing, our paralegal team were providing psychosocial support. We were profiling and follow-up cases that were actually inside. We are giving legal aid clinic, provision of hygiene kits, formation of support groups, link between the criminal justice, integration. All these services were actually provided prior to COVID outbreak. After COVID outbreak, everything came to a standstill. It was a very tough moment for us as service providers and inmates, especially people who use drugs, who are actually at the prison, the withdrawals, and all this. And during the COVID pandemic, majority of people who use drugs were the ones who were actually being caught and sent to the prison. So it was quite a heavy burden for us, for both of us and the prison authority, because they didn't have expertise and the withdrawals were just piling up in big numbers. Next slide, please.
Recibido números muy altos. Ahora los logros. Esto es lo que estamos discutiendo ahora después del COVID-19.
Was established, it was a leeway. People from the prison, all the inmates could actually access methadone with unconditionally. The methadone clinic also gave the local community within the precincts of the correction facility to have access to the methadone for the methadone. So what we have seen here from the achievement of the establishment of the methadone clinic was improved access to health and human rights for the people who use drugs. Anyone in Kenya at the moment along the coast, unfortunately, these services are not spread throughout the country. Here on the coast is where you get any person who is a drug user and has conflict with the police, as long as he's a heroin user and he accepts it to the law, to the court, he is actually given a court order for enrollment to methadone program. So 100% of new inmates, of people who are actually taken to prison since the establishment of the methadone clinic, 100% of them are directly absorbed into the methadone clinic. So another important, can you excuse me, please, the call for prayer? It's the evening prayers right now. Okay, thank you very much. And sorry, Ramadan is around the corner. It's fasting time. So Alhamdulillah, it's a festive season for us. Yes. So the other thing is, the good thing that we have got from this opening of the methadone clinic at Shimolotewa is replication of methadone MAT clinics in the rest of the country. As we speak, there's another one in the next county that we are working very close to open it up. There are along this region, we almost have 3 MAT clinics that are on the two actually placed on the pipeline. So this is a plus for us. The introduction of referral of harm reduction from judicial system. One big thing that we've been able to achieve from this clinic and the work that we've been doing is the referral system and linkage system from the court, from the law enforcers, and from the CSOs and NGOs. So rehabilitation for methadone, rehabilitation for both outpatient and inpatient programs. A replication of alternative sentencing, the good work that we've been able to do and document here in Mombasa have been able to be documented, and as we speak, it's being replicated elsewhere. People who use drugs in a couple of places, a couple of areas in this country are now given alternative sentencing options against just direct incarceration and stigmatization and marginalization. So referral of people who use drugs from the court to prison, probation, police, to outpatient. So we, the NGO, are now getting a lot of referrals from the police and the rest of the law enforcers for people who use drugs. Another thing that has opened up now that the COVID is gone, access to prison. We're back at the prison, yes. We're back at the prison services, giving out the services that we've been initially giving. However, we are allowed to go into prison only once per week. But at least there is a ray of hope that there is engagement, and we're hoping to open up more. Also, whatever we have been doing right now from the Shimo Mat Clinic and the work that we're doing with the locals, it is a learning practice, as we shall see ahead from the pictures that we have combined. There's a lot of people that are coming, one of them being Harm Reduction International, during their learning, international learning new courses. They do visit Kenya, and specifically, they come to Mombasa to see the good work that we've been doing. Next slide, please. The challenges that we are facing is limited access to gender coverage. The MAT clinic, the Shimolotewa Methadone Clinic or OAT clinic, is placed within a maximum security facility, and for the general member of the community to access this facility is a bit tricky. We have been given us a certain amount of people that we can actually absorb. Another thing is the limited human resource. We still have a serious problem of human resource from the government and the county government. So the CSO are being relied upon to support this, the staff in this facility. Proliferation of drugs into the correctional facility. A challenge that we have witnessed is during the transfer of inmates to the clinic, in and out, they've been getting some drugs and actually being taken to the correctional facility. This has been an issue. And as we speak, now the inmates the drugs, the methadone is actually taken into the prison instead of them coming to access it outside. Limited numbers of limited opportunity. These are the other things. Next slide, please. Yeah, this is what we have been able to achieve since we started this work. Ever enrolled in the math is about 690 people. Ever enrolled in math, 540 people, 504 have been enrolled, and active in methadone is 335. So this is what we have actually, this is a very big achievement, taking this into consideration, but this is just an induction site. It's not, it is just a maintenance site. It is not an induction site. Next slide, please. The next one slide. Another one. Yeah, for a take-home message is for people, for the rest of us to be able to improve on the work that we've been doing, is to familiarize ourselves with the laws and policies of the country and see how best we can actually embrace harm reduction in the work that we are doing. This is exactly what we did. Active implementation of programs lead to realization of the GLAB. Commitment and passion by the CSOs and NGOs that are working on the ground have been able to actually influence policymakers and the rest of the country into accepting what we have been doing. Continuous, our engagement with duty barriers and the community has been continuous because of the stigma and marginalization of drug users is quite big here, especially the Muslim community and African culture. It is quite a serious thing, but regular engagement, regular meeting with these people, and the showing them the impact of health hazard that are around, evolving around drug use. Actually, the community has actually accepted the good work that we're doing. Networking, collaboration with institutions, community leaders, this has been important. Another important thing is innovation. We have been quite innovative in a lot of the work that we're doing. We have actually been able to document a couple of best practices that has actually helped improve the services, because the government are seeing the positive and the community are seeing the positive from our engagement to this. What the parting shot in this is the need assessment. Before us doing any project, we normally do need assessment where we go to the ground and talk to the beneficiaries on what best is working for them. And from this, that's when we go out and roll out our program. Next slide, please. These are the pictures that I managed to compile for this meeting. The first one on the left-hand side, this is a visit by South African head of prison services, the one with this dark shades. They had to come and see the good work that Kenya, specifically MEWA, is doing in terms of alternative sentencing and the methadone program with people. This is Shanzu Law Court. It is actually located next to the maximum prison at the coastal city of Mombasa. And this other slide is the maximum, this is the Shimolatewa maximum prison, whereby we had received some officers from Nairobi. We were on our way to another prison along the coast region. We're about to open up another mat clinic in this area. And down here, this is our office, and these are the Kenya police officers bringing in clients, referral of clients who have been actually caught up with petty offenses. So they are actually referred to us instead of them being taken to prison. And there at the last slide is our meeting with the regional prison commander. He's in charge of all the prison facilities at the coast. We have to have regular meetings with him to update him of our programs, so that if there are new interventions that we bring about. So once we get his blessing, and the work ahead becomes easy. Next slide, please.
I'm so sorry, Hussein, I need to cut you off there because we're running a little bit.
Slides.
Yes, okay, all right, I'll give you
My
one
last slide, thank you. And this is our paralegal officers at the prison talking to inmates, and on the other picture on top on the right-hand corner, these are giving them national identity cards. We do give the prisoners a national identity card. We mobilize the registration officers so that they get the national ID card that help them once they are out. Down here on the left-hand side, the lower side, this is the Shimolatewa Mat Clinic. This is where clients are having sessions. And this is the Shimolatewa Mat Clinic, as you see, and this is how we do our session under a tree. Thank you very much.
Thank you so much, Hussein. That's really a great presentation from you, and I'm so sorry for cutting you off.
I'm through. I'm finished. Asante sana.
Yes. Okay. I would like to invite the next speaker. We have Svetlana Doltu. Svetlana is the director of NGO AFI. She has more than 20 years of experience in TB and HIV/AIDS control, as well as in harm reduction services. She is a regional expert in the right to health in closed settings and non-discrimination. Previously, she was the chief of the medical directorate of the Department of Penitentiary Institutions. Svetlana graduated with a master's in public health management, and she will be sharing her presentation on the right to healthcare in prison during COVID-19 pandemic in Moldova experience. The floor is yours, Svetlana.
Hello, dear colleagues, dear partners, dear friends. I am very happy to be here and discuss about health in prison, and especially about Moldovan experience. And I try to be shorter and to have more time for discussion after our presentations. Moldova is a very small European country. She is placed between Ukraine and Romania, and now we understand all we have a second challenge after COVID, the war in Ukraine. But currently we will discuss only about rights to health in prisons. In general, Moldovan population is about 3 million people. We have 17 prisons in the country, also around 6,000 prisoners, but very high incarcerated rate. If you see, occupancy rate, it's around 90%, but it depends of type of prisons. Usually pre-trial detention centers are overcrowded. If we discuss about health profiles of our detainees, we have the main challenge is hepatitis C, especially. It's about 7% of detainees. Second is drug consumptions, and also we have about 8%. And tuberculosis, HIV is about 1 to 3% of prisoners. In our country, maybe because we are a very small country, we have available in the prison system all treatments available for each citizen in our country. We have RV treatment, we have hepatitis treatment, also opioid agonist treatment, more than 20 years. But we do not discuss about this comprehensive package of services in Moldova prisons. If you discuss about COVID-19, this disease was a challenge for our country, but I think not only for the prison system, but for each of us. We have in prison systems provided about 4,000 of tests, but number of prisoners with confirmed COVID diseases, it's less. We have around 500 people, and there are no deaths of these diseases. In comparison, we have number of diseases among staff, but we have three staff members of prison system died of these diseases. In generally, we see that the situation regarding COVID in prisons, it's not so bad. But what are the challenges when the COVID pandemic began? First of all, there are no knowledge what diseases is and what steps needs to be done by the prison system to control this new challenge for our country. But we have a very good partnership with UNODC, especially Ina Tkac, representative of UNODC in Moldova. And in the first 10 days, we developed together with Ministry of Health, with Prison Medical Department, the rules and first regulation to infection control in prison systems. After in this regulation, we included also the steps and the rules for the continuity of care, including not only for new cases, but also for all prisoners that are stay isolated in the prisons. There are lack of different provisions, consumables, and the mobilization of partners. Do not forget about prisoners that are isolated in prison systems. Was also a very good experience that included the prison staff, prisoners in the whole country response to this challenge. Sure, there are very good communication and sharing of information among Ministry of Health, among community, among NGOs, because there are a very high level of anxiety, not only among prison staff, but also in community in general. And maybe the biggest challenge was to have a good communication with prison staff, to have link and online site included all data about situation in prison system, and this was a very good point. And second, the steps done after these rules and scenario approved for different situation in prisons. But when we discuss about care, for us also in the positive aspects of small countries, we have only one clinical protocol for all population in Moldova. And for diagnostic treatment support, we use in prison the same protocol as in the country. And this was a very good point of equity of care for prisoners and general populations. But also there are a lot of challenges. First of all, restriction, excluded family and intimate visits, and a very high level of anxiety among prisoners because they have a fear to be isolated completely and don't have information about their family, not about only their health. Also, we have restrictions regarding inpatient treatments, or the risk to supply chain interruptions, and especially we discuss about methadone for opioid agonist treatment, because international procurement chain or interrupted, because usually we buy methadone from Ukraine. But due to the good involvement of international agency, always UNODC office, but police, Ministry of Health, there are no interruption in the provision of medicines in country and in prison also. We have insufficient knowledge for emergency response in prisons, because usually we have knowledge only about tuberculosis, maybe something about HIV, but when the situation became very critical regarding COVID, we have the same problem when understaffed prisons have a very high number of sick staff, but also prisoners are in the same vulnerable situation because there are limited access for different services, including access to doctor. Conditional release for prison stopped because the court didn't examine the different petition from the prisoners. And this is the second and the last unimplemented recommendation to decrease number of prisoners due to the criteria of eligibility and decrease overcrowding risk of transmission in prisons. But due to the unfunction of courts, we have different reaction. We have increased number of prisoners staying isolated. But we have also positive aspects, because in each emergency, each challenge, we have an opportunity. And Moldova implemented very good practices like online meetings with relatives, with courts, with family. Especially, I show you later a small video about e-justice rooms for a good communication of prisoners with courts, but also with lawyers, with schools, with relatives. And this was an opportunity for some prisoners to see first time their relatives staying in the different European country. And this was a positive aspect. A second very important point was mobilization of resources and better material conditions in prison, especially for medical care. And we discussed about a lot of humanitarian support provided not only at country level, but also for prisoners. Don't forget it. Trainings for staff, not only medical staff, but in general for staff, and especially regarding COVID and human rights, because these restrictions and correct balance among rights to health for each individual, but in general for community, can be violated. And for us, it was important to have this clear rules and understanding how to implement restrictions. And sure, we have also equivalence of care regarding vaccination in prisons, not only for prisoners, but not only for prison staff, but also for prisoners, voluntary based, because this was a decision for each people to be vaccinated or not. We have a lot of pictures, but small pictures, and especially the first aids offered by UBRA, found by UNODC and UNAIDS, was maybe the first bird. But after, there are a lot of different medical equipment and supplies, medicine offered in for prison staff by Ministry of Health. Vaccination, maybe it's very important to mention that because prison system was part of regional project RISE-VAC, we started the initiative to promote vaccinations in prisons. But we have an idea to start with vaccination of hepatitis, but in reality, we started vaccination of COVID. And we have the same spectrum of vaccines like in community, and we have a very good rate of vaccination among prison staff and prisoners, and higher than in community. And this also is a very good point, because the communication and information done by staff to communicate correct information about vaccines improve the acceptability of these services. This is a e-justice room mentioned previously. Especially they are created in 4 pre-trial detention prisons, because this is the most big fluctuation of staff, and the most important is to have a communication with court, because this is the only one way to decrease number of prisoners in these institutions. You have lesson learned. First of all, equivalence of care for prisoners in the country is a state responsibility. This is not responsibility of Ministry of Justice or of prison administration or only of medical prison staff. And this is very important to have the same approach and to have a responsibility for the people placed in the closed settings. Second very important lesson learned is the support of international agency. when we need to have a good communication and do not forget about prison staff and prisoners when we discuss some policy at country level. Sure, continuous information for prison staff and for prisoners also is very important because we can have accessibility for the vaccine, but if the information is not correct done, the services can be unacceptable. And for us, it's important not only from the general information, but only is the same way to have information regarding the correct knowledge. Digitalizing the justice process promotes the prevention of COVID-19 speed among prisoners. And for us, it's not only a technology, but it's the same control infection measure. And it's a good practice to maintain it after COVID ends. Information accessibility and information material can and must be the same like in community. And for us, it's important to ensure not only paper-based information, but also access to TV, because usually this is a better understandable for all prisons. Ensure continuous monitoring visits of human rights body contribute to prevent ill treatments. And also we have a very good images regarding the continuity of care, accessibility of medicines, and also ensuring of right to health of prisoners. Because lack or insufficient medicines, it's very close to ill treatment. And for human rights point of view, it was very important to have a separate independent opinion of monitoring body to inform Ministry of Health, Ministry of Justice, Parliament regarding the situation in prisons and to confirm what is the real situation. Thank you. And I can to share with you, if I have time, the short 4 minutes video.
Yes, please. We have 4 minutes, Svetlana, for sure.
Thank you. You hear?
Я попал сюда уже во время пандемии. Несколько первых заседаний проводились в здании суда, вывозили. А потом уже, когда карантин ужесточили, общались уже по видеосвязи с судом. Когда вывозят, больше контактируешь с людьми, с персоналом, который тебя этапирует. Больше вероятности, я думаю, заболеть, чем ты находишься здесь. Здесь все-таки более изолированное.
Am folosit și eu camera de e-justice. Am avut o judecată. Nu a trebuit să părăsim locul ăsta, să pierdem o grămadă de timp, să interacționăm cu alte persoane, foarte, foarte obositor, chiar pentru că nu pleci de unul singur la judecăți, pleci cu mai multe persoane, unde trebuie să-i aștepți pe toți pentru o judecată care durează, să zicem, un sfert de oră, o jumătate de oră, trebuia să pierzi o zi.
Ca să-i scotezi deținut în judecată și înapoi, trebuie echipare, trebuie transport, trebuie persoane. De-aia eu mă gândesc că totuși ședințele astea online sunt mai convenabile.
Мы, будучи даже заключенные, живя в правовом государстве, мы как граждане имеем право полностью пользоваться теми же правами и теми же льготами и теми же возможностями наряду с остальными законопослушными гражданами.
David, bună ziua! Bunica vrea să te felicit cu ziua ta de naștere care vine.
Eu vorbesc cu fetele mele din Franța, vorbesc cu nepoțelul. După ce ieși din această convorbire, îți pare că ai fost alături de ei și îți pare că ei chiar sunt în spatele tău, unde îți dau putere să reziști.
Ambii părinții ai mei sunt în Italia și de mai bine de un an de zile nu-i văd pe niciunul. Îi aud, avem posibilitatea de a auzi cel puțin telefonic, dar ar fi o plăcere să-i și văd, să mă vadă.
Да, я год не видел никого из своих. Это очень сложно, и психологически эта атмосфера, она вся давит. Единственная возможность пообщаться с родными, конечно же, через онлайн. Хотел бы пообщаться с тетей, может, с сестрой, с детьми.
Thank you so much.
Thank you very much for partner for this nice video. You can see the material condition in prisons are not so good, but this is a good opportunity to see how the technology can change the life of people in prisons, and especially when we discuss about mental health and possibility to see relatives to communicate and not to be isolated. Thank you.
Thank you so much, Svetlana. Now, to save time, I would like to move on to our last speaker, Beatriz Maldonado. Beatriz, can you hear us?
Okay. See?
Yeah, all right, perfect. Let me introduce you first, Beatriz. Beatriz Maldonado is an activist and graduate of the criminal justice system dedicated to defending the human rights of women inside and outside prison. She is the co-founder and director of the organization Mujeres, Unidas, ex La Libertad, Mexico. Beatriz, I'm very sorry if I pronounce it incorrectly. She has advocated for dignified menstruation for the benefit of women who are deprived of their liberty in Mexico, as well as the issue of torture and support women who have been released by providing accompaniment in the recovery of their identity documents. And Beatriz will talk about the impact of COVID-19 restriction on people in detention in Mexico. Beatriz, over to you. And just a reminder, everyone, Beatriz will be speaking in Spanish, so please choose English channel on your interpretation. Thank you. Beatriz, por favor.
Okay. Muy buenas tardes, buenos días. Bueno.
Good morning, good afternoon. Mujeres Unidas por la Libertad, or Women United for Freedom, has been working in prisons, and what we are doing now is that we are advocating for the human rights of women inside and outside of prisons during COVID-19 pandemic times. Mexico experienced, let's say, that in prisons there was not a real flow of information about the pandemic. The detained people were being told that there was an illness outside that was going to prevent them from receiving visits. Visits were canceled, especially in the first place for children.
Un número exacto de personas que fueron contagiadas de COVID-19, así como también de personas que también fallecieron, porque todo lo mantuvieron hermético. El país no tuvo, digamos, información real, y lo digo porque, por ejemplo, yo en ese tiempo tenía a mi hijo en el reclusorio norte varonil de la Ciudad de México. Él se enfermó de COVID. Él es hipoglucémico, hipertenso desde los 10 años. Y él
Beatriz, I'm so sorry, but we cannot hear the interpretation in English. So
Or
maybe
can you hear the interpretation?
now we can hear, but it was missing for a while. Okay, please continue. I'm so sorry.
¿Lista? Entonces, cuando mi hijo estaba en
Yes,
prisión.
I was saying that my son was in prison in northern Mexico City, and I knew that he was going to be infected. Since he's 10 years old, he has hypertension and hypoglycemia. So he was telling me how many people were being infected with this virus, until one day my son told me that in his section where he was staying, where he was sleeping, one person fainted. He was taken to isolation, an isolation facility. So if you had a flu, if you had a headache, if you had any symptom, what they would do was that they would break into that room and isolate the whole crowd of people staying in that room. Maybe they were not even checking that the person could be allergic to something, and maybe this is why this person was sneezing or had a runny nose or any other symptom. So in this context, everybody was being isolated without being medicated, without medication, without treatment, without testing. And this happened during the whole year of 2020. During this year, my son was infected, and at some point, he lost his ability to breathe. His lips turned purple. There was no medication, no health services, no treatments, as I was saying. I was even crushing some pills, aspirins, and I was putting them in my shoes to smuggle them into prison for my son to mitigate his fevers, his pains. I took paracetamol. There were no other medications there. So, really, the prisons in Mexico lacked all services. We have no stats, no information about COVID-19 in Mexico, in its prisons specifically. And even now in 2023, we have a female prison where we have 5 women who are isolated because they have COVID-19 symptoms, specifically the Omicron variant. They are isolated at the moment, and other women who were in contact with them are really concerned because in the prison system, there is no access to treatment, to medications, and the state is saying that there is no budget for that, no budget for the medications for people who are in prisons. They have no privileges at all. That's what the state is saying. So what we say, what we did during the pandemic times, is that we were connecting with people who were going to visit their relatives in the prisons, and we were sending food, we were sending medicines, we were sending face masks as well, the disinfectant supplies, hand sanitizers. So during 2020 and 2021, we were actually supporting the penitentiary system, the prison system. Our countries were going through chaotic times. There was no capability of addressing this in a logistical way, in a proper logistical way. There is no way to tackle this health or environmental tragedies. Some people are even sick now, many months later, because there is no proper access to healthy food, to medications, as I was saying. And these women who are infected with COVID-19 are experiencing serious consequences in their lungs. They are not stable at all. Many women are experiencing respiratory problems. We are giving them a spray so that this can open their respiratory ways. Again, there was no proper attention. In the case of my son, he was affected every 2 weeks. He's falling sick. There are changes of temperature. He's going through a therapy. And I have to say that it's incredible that these are human beings in the prison system, but they were not treated as human beings. There was a complete lack of attention of health services. There was a tragedy, and we do not know how many people died in the prisons of Mexico. We have no stats, because this is the way how the state has been dealing with it. Even today, we have ill women who are being isolated right now because of the Omicron variant.
All right. Beatriz, are you going to share something, or that's at the end of your presentation?
La tengo en español. Te tengo en español. ¿Dónde le voy a puchar? ¿En subtítulos? ¿Le pongo español? Okay.
This one?
¿Listo?
Yes. Oh, there is no sound.
There you go.
I'm so sorry, it doesn't work as well. There is still no sound. Would you mind if are you okay if we share the file of this video on the chat for all the participants, Beatriz?
Okay.
Yes, okay, all right then. We'll put it on the chat. And I guess now it's time for Q&A. If Hussein is still with us, I would like to invite Hussein to turn on his video as well. Perfect, thank you so much. We already have a few questions on the Q&A box. The first one, I guess, is probably for everyone who can answer it. I will read it, and then any of the speakers who wants to answer can just answer. The question is, how has the suspension of visits impacted detained people's right to consult with their lawyers and their defense in criminal proceedings generally? Anyone wants to answer that?
No.
Hussein here.
Yes, please, Hussein.
Yeah, initially it was tough. Initially, it was very difficult. There was no communication whatsoever. The cases that were there, they just kept on piling. People had no defense there. But after some time, at least there was a ray of hope. Our paralegal officers were allowed to go with a lawyer sometimes. So in the long run, it was eased and they could access but not many, because the list was long and you could just go there once in a while. And it was tough. I think at least there were some cases that could actually be taken care of on our side.
Thank you. Anyone else? Svetlana, Beatriz, or Jen, if you want to answer this one.
Yes, sure. It was a difficult situation. In Moldova, the solution was implemented more easy, maybe, because during the first week, we increased the number of cell phone communications for prisoners, not only limited number, but there are opportunity to have a discussion online using Skype, especially cell phone. But after 3 months, we have an opportunity to visit physically prisons, but with infection control measure restriction. And the justice room, especially, because I think this is the best way to continue.
Thanks. Yes. Beatriz, are you going to, do you want to answer that one as well, or should we move on to the next question?
Lo tengo en inglés, English.
In Spanish,
No,
fine.
Spanish, no.
We still have the translator.
Interpretación. Inglés.
In Spanish, it's okay. In Spanish.
Beatriz, en el canal de español, por favor.
No me lo da.
That's fine. That's fine. If you we can move on to the next question probably. And just let me know if you want to answer any of the questions. The second question is actually very interesting one. This is probably for Jen. What was the main barrier in getting completed surveys? Was it willingness from the officials or maybe other factors?
Thanks, Ajeng. I'm actually not sure if that question is directed at us at HRI for the report. Does the person who asked the question want to clarify if that's for us, or was it for somebody else?
Please go ahead. I think Aditya, yeah.
Yes, it was, sorry, I should have been clear. Yeah, it was meant for the report that you presented at the beginning.
Okay, thank you. Thanks for clarifying. I don't think it was. I don't think that was the main barrier because it went out to mostly civil society. It wasn't sent to government officials so much as civil society. I think the main barrier is probably that people don't have very much time. People are very busy. So we did get a low completion rate for the survey responses, but the people who did respond, you know, answered as well as they could and offered quite a bit of information. So I think I'm not answering the question very well, but it wasn't the fact that governments didn't want to respond. The question did go out to civil society mostly. I don't know if Marcela wants to chime in on that. She was more involved in the survey part of the report.
While Marcela preparing her answer, I think Svetlana also raised her hands and wants to answer that one.
Just a moment. Second, maybe it's the problem of English. Usually in our part of country, not a lot of officials, especially for prison system, have knowledge to can complete the survey. And maybe for the next time will be okay to have in the same survey more or 3 languages. And this can be maybe more useful and more involved in responses.
Thank you, Svetlana. That's a great point. We did, I think, have it translated in a few languages, but obviously not enough. So that's really an important thing for us to consider next time. Thank you.
Thank you so much, both. All right, should we move on to the next question then? We got a question from Tripti. Were people in prisons with comorbidities and chronic ailments treated differently in terms of COVID prevention or treatment or access to early release? I would welcome anyone who wants to answer that one.
Beatriz,
Yes.
want to be first?
No, perdón. Excuse me, no,
Yes.
no las trataron diferentes. Todas fueron tratadas igual, es más.
No, they were not treated in different ways. Everybody was treated in the same way. They didn't even care that women with chronic illnesses were receiving proper attention. There was no medication, no treatment at all. We as activists started buying lots of aspirin, and we were handling them to people who were suffering of chronic illnesses, diabetes, for example, hypertension. They were not being treated. As I mentioned, my son has chronic illnesses and he was not receiving any medication. So we had to be helping them.
Thank you so much, Beatriz. Svetlana, do you want to answer that one as well, please?
Yes, sure. We have maybe two mechanisms. In Moldova, we have an order regarding approved by Ministry of Justice and Ministry of Health regarding a list of diseases that can be a reason for early release due to their health status. Usually, we have a second part that during the COVID period, the court didn't work. And if you send the document for examination, they also are not released in time for the very serious diseases. When we discuss about emergency situation and the recommendation very clear explained by UNODC, WHO, to have release for different eligible people from prison to decrease overcrowding and to exclude the contact for the vulnerable groups of population to have diseases. This was one of the biggest challenge because our Ministry of Justice, our country, do not implement this recommendation. And this was mentioned in all reports, including of Ombudsman and of all NGOs working in this place. This is a challenge because usually we have applied different type of early release, including maybe from degree of president or something. But for prisoners, do not apply this a very clear rule to decrease number of people, and this is a challenge.
Thank you, Svetlana. I know we are 2 minutes past the time, but there are two more questions. I think if it's okay with the panelists, we can take these two last questions and then we will wrap up and close the webinar. The next question is for Hussein. Hussein, can you please share a bit more on the purpose and activities of the MEWA Learning Center? Sorry, Hussein, you are still on mute.
Sorry.
Yes.
Now, actually, what we have is we have a combination of different services that we give out to the community. We have drop-in centers, we have rehabilitation center, and the mat clinic. So these are the three areas that people would come and see the work we are doing. So normally what happened is we would you start with the DSC and see the different services that we are actually doing. Then we'll be having get some time to go to the drug dens and see the interaction of what is happening on the field. So this is actually in a nutshell, this is what we're doing. And sometimes for students specializing learning, they will actually be attached to their respective DICs or the rehabilitation centers for them to learn as the courses that we're doing. So what has been happening? UNODC has been instrumental in this. most of their trainings or in East Africa, and East African region, they would actually bring them to Kenya, and in between they would come to the ground and see how we are actually conducting our work. And thank Harm Reduction International also has been coming to Kenya, and specifically has been coming to Mombasa. We really thank you for this and for taking some of our staff to the rest of the world to see the programs that have been working well. So this is what is happening actually.
Thank you so much, Hussein. And we have last question before we close. The question is there any evidence of compensation for those infected and died in prison setup? He says that people don't go to prison to die. Definitely. Any answer? Anyone wants to answer that one?
No. From my side, I don't think we have any. In Kenya, we don't have such compensation.
The good point for Moldovan prison, we have no death among prisoners by COVID. This is a good point. If you discuss about compensation at country level, including for the prison staff, medical and non-medical staff, we have a compensation like infection at the workplace. It's one payment about $1,000, like this, yes? If we discuss about, but it needs to be demonstrated that you respect the infection control measure, and this is the infection due to the professional activities. And also, second, also for a country level, we have a compensation for families that lost their family member, especially medical staff, due to the activity in hospitals or their police members, prison staff. We have the same modality, but what are the people who accessed this opportunity? I have no data because I didn't think about, but exists. Thank you.
Thank you, Svetlana. Beatriz, do you want to answer that one? Yes, please.
Sí, nosotras, bueno, sí ha habido un poco de compensación económica.
Yes, there is some kind of financial compensation for relatives specifically. Not in terms of the population or the communities or the people in prisons. We are talking about civil society, for instance, but only for people or elderly people who are eligible for this kind of compensation, who have died or have had a dead a relative, a son or a girl. This is specifically in Mexico.
Thank you so much, Beatriz. All right, I think we probably need to end it here. Thank you so much to all the panelists, speakers, and thank you for everyone who have joined us today. I hope this session, this webinar, you have learned about the experiences, challenges, best practices, lesson learned on addressing COVID-19 in prison setting, especially in these three respective countries, as well as from our report. I would also want to close by saying and link our conversation with the pandemic treaty process again, and say that pandemic treaty is a unique opportunity to ensure domestic authorities comply with their obligations to protect the health and rights of people deprived of liberty ahead of and during the next pandemic. And we hope that the information you received today would be useful in supporting you to encourage your government to negotiate the treaty to prioritize this population. Thank you so much, and see you in another webinar next time.
In Kenya, we discussed already. In Kenya, in Mumbai.
In Mombasa, yes.
Anytime. Karibu sana, welcome on.
And we
See
are
you soon.
waiting for you in Moldova.
Yes.
Inshallah.
Muchas gracias, Beatriz.
Thank you. Muchas gracias. Muchas gracias.
Asante.
Bye.
Thank you, asante sana, asante sana.
Bye.